Hello, this is Dr. DIVYA JAMLOKI back again with a new video on acute rheumatic fever. So now, what is this acute rheumatic fever? Acute rheumatic fever is an autoimmune multi-system inflammatory non-suppurative disease. Remember my words that this disease is completely non-suppurative. There will be inflammation but there is no suppuration in this disease. सो नाउ जब भी हमारी बॉडी में ग्रुप ए बीटा हिमोलिटिक स्ट्रेप्टोकोकल इन्फेक्शन होगा तो उसके अगेंस्ट हमारी बॉडी एंटीबॉडीज़ बनाएंगी और वो एंटीबॉडीज़ हमारे खुद की ह्यूमन टिश्यू के साथ क्रॉस रिएक्ट करेंगे. Now what happens is there is infection with group A beta hemolytic streptococcus which leads to upper respiratory tract infection. An episode of acute rheumatic fever. So either there is a single episode of acute rheumatic fever or whenever there are recurrent episodes of acute rheumatic fever, both can lead to rheumatic heart disease. Now talking about the global consideration of this disease, the burden of disease is found more in the developing countries. 95% of the rheumatic heart disease is found in developing countries. It is found mostly in South Africa, South and Central Asia. So the burden of disease is more in developing countries. Talking about the age group, 5 to 15 years children are more affected by rheumatic heart disease. Now let's talk about the pathogenesis of the disease. Although classically it was said that certain M serotypes like 1, 3, 5, 6, 14 were associated with acute rheumatic fever. But nowadays they are saying that any strain of group A streptococcus can cause acute rheumatic fever. Okay. Now talking about the host factors, that monozygotic twins have more susceptibility towards the rheumatic heart disease more than the dizygotic twins. Also talking about the HLA association, HLA-DR4 and HLA-DR7 have more susceptibility towards acute rheumatic fever. सो लेट्स टॉक अबाउट द इम्यून रिस्पॉन्स. सो जैसे मैंने पहले आपको बताया था कि हमारी बॉडी एंटीबॉडीज़ बनाएंगे और वो एंटीबॉडी खुद ही हमारी ह्यूमन टिश्यूज़ के साथ क्रॉस रिएक्ट करने लग जाता है. तो इस कंसेप्ट को बोलते हैं मॉलिक्यूलर मिमिक्री. दिस इज द मोस्ट वाइडली एक्सेप्टेड थ्योरी ऑफ द rheumatic fever pathogenesis. That is molecular mimicry, an immune response targeted at streptococcal antigens. अभी streptococcal antigens जिसके against हमारी बॉडी एंटीबॉडीज़ बना रही है, that is your M protein. You can see in the diagram M protein. Okay, so now what will happen is the cross-reactive antibodies will bind to the endothelial cells on the heart valve, which will lead to the activation of VCAM1. You can study this VCAM1, which is an adhesion molecule, in the inflammation chapter of the pathology books. Just go once through the book and you can learn about the VCAM molecule. Okay, so whenever there will be activation of VCAM molecule, there will be recruitment of the activated lymphocytes and endothelial cells का lysis हो जाएगा, which will lead to the release of peptides. So peptides like keratin, tropomyosin, they will further activate the cross-reactive T cells that will invade the heart and further amplify the damage. So this was the whole concept of molecular mimicry. So now let's talk about the morphology of rheumatic heart disease. You can see in the diagram there are Eshkov bodies. Eshkov bodies is the pathognomic feature of the rheumatic heart disease. This is very important for MCQ per se, or this question can be asked in your Viva also. You can see in the center there is fibrinoid necrosis. Surrounding it are the activated macrophages with abundant cytoplasm. They are known as caterpillar cells, owl eye or Anish-cow cells. This is very important point. Also you can see the black dots, these are the lymphocytes surrounding them. Now caterpillar cells are known as Anish-cow cells or owl eye. So these are the activated macrophages with abundant cytoplasm. So Eshkov bodies are very important pathognomic feature. Now we'll talk about the clinical features. So there is a latent period of 3 weeks between the precipitating group A streptococcal infection and appearance of the clinical features of acute rheumatic fever. The most common presentation is polyarthritis, which is seen in 60 to 75% of cases. Chorea, which is seen in less than 2% to 30% of the cases. Carditis is seen in 50 to 60% of the cases. Erythema marginatum and subcutaneous nodules are very rare. Let's talk about the heart involvement in the case of acute rheumatic fever, which is also known as rheumatic heart disease. The first one is rheumatic pericarditis. So, if we talk about the pathology part of the rheumatic pericarditis, we will see the bread and butter pericarditis because of the fibrinous exudate in between the pericardial layers. So, patient will experience chest pain. Patient will get relief on lying forward. On examination, you will find pericardial rub, that is a scratchy sound produced due to pericardium rubbing against each other, and on ECG you will see ST elevation, and that will be concave upwards, remember it. Now we'll talk about the rheumatic myocarditis. This is the most dangerous complication of rheumatic fever because myocardium becomes loose and flabby, and it can further lead to congestive heart failure. Now, what about rheumatic endocarditis? The most common valve affected is mitral valve, and in the acute cases, what you will see is mitral regurgitation, and in chronic rheumatic heart disease, you will see mitral stenosis. The pathology per se part of the mitral stenosis is fish mouth or buttonhole stenosis, mitral valve thickening or shortening and thickening of chorda tendineae, which I will show you in the pictures or slides, and rheumatic vegetations. One important thing I will mention here is McCallum plaques. So what is McCallum plaques? तो जब भी mitral regurgitation होगा तो blood will flow from left ventricle to left atrium. So what will happen? There will be abnormal thickening of the endocardial surfaces, that is known as McCallum plaques. One more important thing is a murmur, which is Carey-Combe murmur, and this is a mid-diastolic murmur. Now let's study these images. The first one is showing the rheumatic vegetation. They are small 1 to 4 millimeter, warty vegetation, verrucaceous vegetations. Okay, in the second picture, they are Eschkoff nodules, as I've mentioned before in the slides. And the third one is fish hole or button mouth stenosis. Fourth one is showing the thickening of chorda tendineae. Now let's study about the other manifestations of acute rheumatic fever. The first one we'll talk about is joint involvement. The most common presentation is arthritis. So this is the most common and earliest manifestation, which is seen within 2 weeks of history of sore throat. And the second important point we will see here is that there will be involvement of more than one joint. So this is polyarthritis. Third important point about joint involvement is that this polyarthritis will always be migratory, affecting, it jumps from one joint to another joint. So this is a migratory polyarthritis, which is mostly seen in USA. In India, you can see monoarthritis or polyarthralgia also. So now the next one, which joints are affecting more by acute rheumatic fever? They are large joints like knee, elbow. Such joints are affected more by the acute rheumatic fever. So in Korea, you will see Sydenham's chorea or St. Vitus dance, which is due to the damage of caudate nucleus. What is this Sydenham's chorea? So you'll see fast, purposeless, involuntary distal movement. Also, children will have poor handwriting, and due to which their school grades will be low. Patient can also present with jerky speech. There will be hypotonia, emotional liability. On examination, you will see darting tongue, which you can see in this picture also. They will be unable to keep their tongue in the stable position. Also, I will tell you about milkmaid grip. That patient is unable to generate that persistent hand grip. Okay, the third one is dysarthria. Dysarthria and also hung up ankle jerk is also manifestation, CNS manifestation of acute rheumatic fever. So the darting tongue, milkmaid grip, dysarthria and hung up ankle jerks are the signs of CNS manifestation, and Sydenham's chorea and also, which is also known as St. Vitus dance, that is occurring due to the damage of caudate nucleus. Now we'll study about the skin involvement. We can see erythema marginatum in the first picture, that is non-pruritic. There will be no itching. Okay, pink macular erythema center shows clearing and periphery shows outward spread. Now subcutaneous nodules are painless, small, short-lived. Other features are fever, which is in the minor criteria. Now we'll study the workup. We'll do a throat swab culture, rapid antigen test and serologic tests. What are those serologic tests which are very important? These are anti-streptolysin O and anti-DNase B titers. We will see them. Now we will study about modified Jones criteria, जो बहुत ज़्यादा important है for MCQ per se और for viva questions. This is very very important. और जब भी when you will write about rheumatic heart disease, you have to write about modified Jones criteria. Without this, your answer is totally incomplete. तो मेजर मैनिफेस्टेशंस क्या है ऑफ एक्यूट rheumatic फीवर? तो जो भी हमने क्लिनिकल फीचर्स में पढ़ा था, सबसे पहले हमने पढ़ा था कार्डाइटिस, फिर हमने पढ़ा था पॉलीआर्थराइटिस, कोरिया, एरिथमा मार्जिनेटम एंड सबक्यूटेनियस नोड्यूल्स. ये पांचों के पांचों आर द मेजर मैनिफेस्टेशंस ऑफ एक्यूट rheumatic फीवर. अब उन्होंने माइनर क्राइटेरिया में किस चीज़ को इंक्लूड किया है? फीवर. जो हमने पढ़ा था अदर फीचर्स में फीवर, दैट इज इन द माइनर क्राइटेरिया. फीवर, पॉलीआर्थ्रेल्जिया, लेबोरेटरी इन्वेस्टिगेशंस में एलिवेटेड ESR और एलिवेटेड ल्यूकोसाइट काउंट एंड ECG में प्रोलॉन्ग PR इंटरवल. दिस इज इंक्लूडेड इन द माइनर मैनिफेस्टेशन ऑफ द acute rheumatic fever. इसके साथ साथ यहाँ पे क्या होगा? There should be a supporting evidence of a preceding streptococcal infection within last 45 days. Within last 45 days, remember it. So यहाँ पे क्या होना चाहिए? या तो elevated anti-streptolysin O आपका एलिवेटेड, मतलब इसके टाइटर्स एलिवेटेड होने चाहिए, या फिर आपका पॉजिटिव थ्रोट कल्चर होना चाहिए, या फिर रैपिड एंटीजन टेस्ट फॉर ग्रुप ए स्ट्रेप्टोकोकस पॉजिटिव होना चाहिए. तो इन तीनों में से ये एक सपोर्टिंग एविडेंस होना चाहिए मेजर और माइनर क्राइटेरिया के साथ. तो अभी इन्होंने क्या बोला है कि अगर आपका प्राइमरी एपिसोड है rheumatic फीवर का, तो या तो 2 मेजर क्राइटेरिया या फिर एक मेजर क्राइटेरिया और इसके साथ 2 माइनर क्राइटेरिया प्लस आपका एविडेंस होना चाहिए. और एविडेंस वही है जो हमने पढ़ा था, एलिवेटेड टाइटर्स, पॉजिटिव थ्रोट कल्चर, इनमें से कोई भी एक, तो ये होना चाहिए. सेकेंड, अगर बार बार rheumatic फीवर के अटैक्स आ रहे हैं तो 2 मेजर क्राइटेरिया या फिर एक मेजर क्राइटेरिया प्लस 2 माइनर क्राइटेरिया प्लस एविडेंस ऑफ प्रीसीडिंग ग्रुप ए स्ट्रेप्टोकोकल इन्फेक्शन, जस्ट लाइक द प्राइमरी एपिसोड. अब हम पढ़ते हैं अमेरिकन हार्ट एसोसिएशन रिकमेंडेशन फॉर ड्यूरेशन ऑफ सेकेंडरी प्रोफाइलैक्सिस. तो हम इसमें एंटीबायोटिक्स देते हैं. अगर कार्डाइटिस के बिना rheumatic फीवर है तो आप 5 years का प्रोफाइलैक्सिस एंटीबायोटिक्स देते हो. अगर कार्डाइटिस के साथ है या फिर परसिस्टेंट वॉल्वुलर डिजीज़ है तो तब आपको 10 years के लिए एंटीबायोटिक्स देना पड़ता है. Thank you for watching this video. I'll be back again with a new video. Do like, share and subscribe Khan's Academy for amazing content. Thank you. Bye-bye.